Welcome to the Depth Dive. Today we're taking a real surgical scalpel to one of the most vital areas in medicine, operative obstetrics. And this deep dive is really for you if you're a medical student, a junior doctor, anyone who needs to get past pure theory and, straight into clinical mastery.
Our whole framework for this is built on a really foundational text. It's the latest edition of Munro Kerr's Operative Obstetrics.
Which has been around since 1908, right?
It has, but what makes it so useful now is how it merges that old school art of practice with, hard evidence, right down to the latest Cochrane review.
It's that blend of wisdom and data.
Exactly.
Yeah.
And you can't really talk about this field without mentioning J. Munro Kerr himself. He was the one who just fundamentally changed how we do things. He popularized the lower segment C-section, what we call Kerr's operation.
Which was so much safer than the classical incision.
Oh, massively. And that really sets the stage for how we think about intervention.
But first, you have to understand the baseline.
You have to. Before we talk about intervening, we have to start with the fundamental mechanics of normal labor.
Okay, so where do we begin?
You have to internalize this one core concept. Human labor is basically the result of the uterine corpus contracting powerfully while the cervix yields.
Right.
And the text gives this superb visual analogy for it. It says, imagine you're trying to put on a brand new, very tight roll neck pullover.
Okay, yeah, I can picture that struggle immediately.
The head, in our case, the fetal head, it has to be flexed to present its smallest diameter.
And the cervix is the tight neck of the pullover.
Exactly. And it's forced to efface and dilate not just from pressure, but from the relentless traction of the myometrial fibers.
Ah, so they're like your arms pulling the jumper up and over your head.
That's the driving force, that traction.
Okay, so let's unpack the biochemistry of that traction. What's the molecular engine here?
Well, the engine is actually pretty simple, but very precise. You need actin and myosin to combine into the active filament, actinomyosin.
And that's the contraction.
That is the contraction. And that whole reaction is fundamentally calcium dependent. It's catalyzed by a specific enzyme, myosin light chain kinase.
And the calcium itself, its availability is managed by hormones like oxytocin and prostaglandin F2 alpha.
Yes, they help it get into the cell and get released from stores.
So if that kinase is the key enzyme, that's the so what for clinical practice, isn't it?
Precisely. That tells you exactly how to stop a contraction.
Right. If you have preterm labor or uterine hyperstimulation.
You're aiming to inhibit that mechanism. You're trying to reduce calcium availability or block its effects downstream. That's where the basic science directly informs your acute intervention.
What's fascinating is the idea of labor initiation itself. It just sounds too important to be a simple on-off switch.
It is. It's almost certainly a multi-redundant biochemical cascade.
A fail-safe system.
A fail-safe. It's too important to rely on one signal. And the most cutting-edge understanding is that the signal actually comes from the fetus.
The fetus is dictating its own eviction notice. This is where it gets really interesting.
Yes. The signal seems to start when the fetal brain matures and activates its own HPA axis. So that's the hypothalamic pituitary adrenal axis.
Okay.
This releases corticotrophin and oxytocin. And the fetal cortisol kicks off this beautifully coordinated sequence. It stimulates pulmonary surfactant to mature the lungs.
While at the same time.
It's transforming that rigid cervix into a pliable, compliant structure that's ready to dilate.
It's a synchronized clock. Incredible.
It really is.
So let's pivot from that to a huge clinical challenge. Preterm labor. The book lists some very clear risk factors we all need to recognize.
And they are critical for risk stratification. We're looking for, extremes of maternal age and BMI, Black ethnicity, socioeconomic disadvantage.
A previous preterm birth is the biggest one, right?
It's the single biggest predictor. That and a short interval between pregnancies.
Okay, so for an asymptomatic woman who is at risk, how do we predict who's actually going to deliver early?
We have two primary screening methods that are pretty effective. First is an ultrasound measurement of cervical length. A short cervix is a big indicator.
And the second?
The detection of fetal fibronectin, or FFN, in the vaginal fluid.
Explain that one. What is it?
Fetal fibronectin is basically the glue between the fetal membranes and the uterus.
I see.
So if you find it in the vaginal canal, it suggests that interface, that glue, is starting to break down.
That makes sense. Okay, let's talk management. Specifically, preterm, pre-labor rupture of membranes, PPROM, at 34 weeks or more. This is a classic trade-off in the evidence.
It really is the classic balancing act for a clinician. You're comparing immediate induction versus expectant management. and the evidence shows competing risks.
Okay, what are they?
Expediting delivery. So inducing labor, it actually increases the risk of neonatal respiratory distress syndrome.
By how much?
The relative risk is 1.26, and it also increases the likelihood of a caesarean section by the same amount.
So why would immediate induction increase the C-section rate?
It's likely because you're inducing a non-ready uterus. The cervix is often unripe, and the induction might just fail, leading to an operative delivery.
But there's a benefit to inducing.
There is. You reduce the risk of chorioamnionitis, maternal infection, by half, an RR of 0.50.
So it's a very personalized decision between the clinician and the patient, weighing those risks.
It has to be.
Speaking of induction, reading the history of it in the source material is wild. They tried everything from white amber and white wine to cervical sponges.
It makes you appreciate modern pharmacology.
Yeah.
But the risk-benefit calculation is still just as important, especially for the fetus.
And the data on early delivery and long-term risk is, well, it's pretty sobering.
It absolutely should inform our practice. Population data is very clear. The risk of a child having special educational needs, or SEN, is lowest for deliveries at 40 or 41 weeks.
Okay.
If you deliver at 37 weeks compared to 40, you increase that child's subsequent risk of having SEN by 36%.
Wow, 36%.
So we have to internalize that. Induction should only be for pregnancies where the benefits clearly, unambiguously outweigh these known risks.
So when we do induce pharmacologically, what's the modern method of choice?
Vaginal prostaglandin E2, or PGE2.
And why is that preferred?
It's effective for both cervical ripening, so making the cervix soft and ready, and for initiating the contractions themselves. It's also linked to lower rates of postpartum hemorrhage and higher maternal satisfaction.
What's the main acute risk to watch for?
Uterine hyperstimulation. Contractions get too frequent or too long.
And you treat that with a tocolytic like terbutaline.
Exactly, to relax the uterus quickly.
Which leads us straight into surveillance. CTG mastery. Let's break down the interpretation framework.
Okay, so we use the NIAID guidelines. Normal, suspicious, or pathological. A fundamental sign of a healthy, non-hypoxic fetus is the presence of accelerations.
A sudden rise in the heart rate.
A sudden rise of more than 15 beats for at least 15 seconds. If you see 2 of those in 15 minutes, you have a reactive healthy trace.
Conversely, decelerations signal stress. When do we need to start thinking about intervening?
The ones you must focus on intently are the atypical variable decelerations.
Okay, what makes them atypical?
They have these very specific concerning characteristics. It suggests there's both cord compression and some underlying uteroplacental insufficiency.
So you're looking
for a late recovery back to the baseline, the loss of the protective shoulders on either side of the dip, or any deceleration that is just too deep or too long. So more than 60 seconds, or a drop of more than 60 beats. If you see those, the CTG is abnormal.
And how fast is that fetus running out of time? What's the timeline for acidosis?
It really depends on the pattern. A fetus with persistent late decelerations might become acidotic in about 90 minutes.
And other patterns.
One with severely reduced baseline variability might take longer, maybe 190 minutes. But, and this is critical, you have to look at clinical modifiers.
Like what?
The presence of thick meconium in scanty amniotic fluid. That will significantly accelerate the rate of hypoxia and acidosis.
Okay, let's pivot to physical intervention. Assisted vaginal delivery. We know forceps use has gone down, vacuum use has gone up. But before any of that, what are the non-negotiable prerequisites?
The checks are absolute. Cervix must be fully dilated, membranes ruptured. You must know the precise fetal position, and the head has to be low. Ideally, you can feel 1/5 or less of the head abdominally.
So why that trend shift? Forceps down, vacuum up. As a junior doctor, why should I care?
It's a really complex issue, but it's driven mostly by training and the perception of risk. Forceps requires a higher skill set, especially for rotation, and historically it was linked with more maternal trauma.
And vacuum is seen as easier.
It's generally perceived as easier to learn and apply. But, and this is the key, for complex deliveries like a deep transverse arrest, you often need specialized rotational forceps, like Keelan's.
So for those rotational deliveries with Keelan's, what's the mechanical goal?
The goal is gentle rotation. You follow the path of least resistance to get the head into that occipito-anterior position.
And there's a specific feeling.
There is. As the head successfully rotates past the ischial spines, the operator feels this characteristic, satisfying clunk.
That's the feedback.
That's the feedback. And you contrast that with the absolute contraindication. Never, ever attempt a vacuum delivery in a known face presentation.
Now for the highest acuity emergency. Shoulder dystocia. Time is everything.
This is a mechanical failure, and we fix it mechanically.
First maneuver.
Universally, McRoberts position. You hyperflex the maternal legs back against the abdomen. This straightens the sacrum and opens up the pelvic diameter.
And the success rate is pretty high.
It's fantastic, 40 to 90% often.
And if McRoberts fails, what's the progression?
You follow the sequence. McRoberts is first, then controlled suprapubic pressure to dislodge that anterior shoulder.
Yeah.
If that fails, you go to internal rotational maneuvers. You can sweep out the posterior arm.
To reduce the shoulder diameter.
Correct. Or you perform the wood screw maneuver, rotating the posterior shoulder.
And the one thing you must never do.
Avoid hard, downward, or quick traction on the fetal head. Do not pull down. That specific action is what's strongly associated with stretching or tearing the brachial plexus. Permanent injury.
Finally, let's touch on the rising complexity of surgical delivery. With C-section rates going up globally, placenta accreta syndrome, or PAS, is a huge driver of maternal morbidity now.
It really is. PAS is where the placenta implants abnormally, usually into the scar from a previous surgery. It can be life-threatening. Maternal mortality is up to 7% in some series.
And it requires a whole team.
It requires a specialized multidisciplinary team. And delivery is often planned early, between 34 and 36 weeks, to avoid spontaneous labor and hemorrhage.
What's the most dangerous surgical zone for PAS?
Oh, the key danger point is extensive lateral perimetral invasion.
And why there?
Because of the proximity to major pelvic vessels. The internal iliac arteries are right there. Hemorrhage can be absolutely massive and uncontrollable. Sometimes it requires a planned peripartum hysterectomy to save the mother's life.
And our last clinical challenge, vaginal birth after caesarean, or VBAC. What's the primary, rare, but catastrophic risk we counsel for?
The possibility of complete uterine rupture.
And the risk is low.
The absolute risk is low, about 3 to 7 per 1,000. But that risk is hugely compounded by certain induction methods.
Which ones?
Specifically, using prostaglandins like misoprostol for cervical ripening. That carries a significantly unacceptably high risk of rupture compared to spontaneous labor or, say, mechanical methods like a Foley balloon.
We have really journeyed from the microscopic action of myosin light chain kinase all the way to the surgical management of PSS, always connecting that foundational science to the clinical decision.
And that integration is how we get better. It underlines why we need continuous audit and evaluation. Using systems like the 10-group classification system, the TGCS, helps units really assess their C-section rates properly and analyze why they're doing them.
So as we wrap up this deep dive, let's leave you with a final clinical problem that ties together the principles of uterine mechanics and intervention we talked about at the very beginning.
Okay. Imagine a patient presents with a retained placenta after delivery. How would you clinically differentiate between two distinct things? A trapped placenta, where the cervix is clamped shut, versus placenta adherens, where the myometrium has failed to contract and shear it off.
Think about the core mechanisms we discussed.
Traction versus contraction. What key clinical signs or ultrasound findings would guide your initial diagnosis? And crucially, how would that difference lead you to choose between giving a tocolytic to relax the cervix or an oxytocic to make the uterus contract?
Ponder that differential diagnosis. Keep exploring your sources, and we will catch you next time for another deep dive.